Welcome. Thank you for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General.
My name is Maria. I am a public health intern with the Blum Center.
Today's program is part of our Cancer Center series, a special collaboration between the Blum Center and the Cancer Center at Mass General. Before I get started, I want to go over a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, it'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Please note that you are in listen-only mode. Everyone has muted so we can hear our guest speaker today. If you have any questions for our guest speaker, you may use the chat feature, which is located at the bottom of your screen. We'll have time for them in the end. Only Blum Center staff and our guest speaker will see your questions. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we'd like to ask you to help us complete. Your feedback is important to us as we plan future programs. Okay, so next I'm going to turn it over to Maria, who will introduce you all today's guest speaker.
Thanks, Amy. Jenny has worked at Massachusetts General Hospital for 14 years, first as a clinical research coordinator in pediatric radiation oncology, then as a floor nurse on a medical oncology unit. She's currently a nurse practitioner in medical gynecologic oncology, where she has found her passion in caring for women with ovarian, endometrial, vaginal, and cervical cancers. She joins us today to give a talk on advanced ovarian cancer, diagnosis, treatment, and future directions. Please join us in welcoming Jenny.
Thank you very much, Amy and Maria. Okay, I'm going to just share my screen here. And we'll get started. Okay. So like Amy and Maria just said, I'm Jenny Filipi. I'm a nurse practitioner in the Department of Gynecologic Oncology at Massachusetts General Hospital's Cancer Center. Today, we're going to be talking about advanced ovarian cancer, the diagnosis, treatment, and some future directions. Oops, so sorry. There we go. First, we're going to start out by talking about statistics, subtypes, and then we'll move on to the initial or upfront treatment of ovarian cancer. Well, we missed it by a month, but September was Ovarian Cancer Awareness Month. We used the teal ribbon. As you may know, October is Breast Cancer Awareness Month. You can't turn your head without seeing pink. They've done such a good job about raising awareness. But ovarian cancer is a much more rare disease, and we'll kind of go through all of that and talk about early signs and symptoms, and then we'll get into the bulk of how we diagnose and treat. So just a quick note, when I'm talking about ovarian cancer today, I'm also talking about fallopian tube and primary peritoneal cancers. You or a loved one may have been diagnosed with any of these, but the difference is really academic. So I'll just be saying ovarian cancer during this presentation. So estimated cases for this year alone are just under 20,000. When you compare that with breast cancer, that's over 300,000 new cases a year. So you can see how breast cancer gets much more attention than we do. The median age at diagnosis of ovarian cancer is 63. So these are women who have are probably about to go through a life change. Maybe they're about to retire, or they have retired. Maybe they're doing some traveling, have a grandkid on the way, and they're hit with this diagnosis. 70 to 80% of women are diagnosed with advanced stage, so stage 3 and 4. We'll go into that in just a little bit, and we'll talk about why that is as well. And then about 80% of women with this advanced cancer will experience a recurrence of this cancer. Despite a complete response to their upfront treatment. So much more work to be done. So ovarian cancer symptoms are very vague. They're things that we have all experienced in our lives: abdominal bloating, some abdominal discomfort, maybe with your period, back pain, constipation, these things that we have all experienced from one time or another. So sometimes the workup is a bit delayed, and then people are presenting later with advanced disease. I always say, though, things that come and last a couple days, usually we don't worry too much about. But of course, if you're having something new, a new symptom in your life that has hung on for more than a couple days or a week, you should go see your primary care and get checked out. And then unfortunately, unlike breast cancer, cervical cancer, colon cancer, there's no screening available at this time for ovarian cancer. So this is another reason that it is caught usually so late. Here's a depiction of the staging. So there we go. Stage 1 is early disease. It's confined to the ovary. Stage 2 has moved out of the ovary, but it's close by. Stage 3 has spread to the lymph nodes, but it's confined to the abdomen. It could be on the lining or the peritoneum of the abdomen, or it could be on the surface of the liver or the spleen. And then stage 4 has spread to the lymph nodes outside the abdomen. It could be in the lung, spleen, liver, or brain. And again, we're going to be concentrating this talk today on stage 3 and 4 advanced stage disease. So I did want to let you know that ovarian cancer can look completely different when you look under the microscope. There's all different types of subtypes. What we see most is epithelial ovarian cancer, cancers that come from the lining of the ovary, and most of this is the high-grade serous type. This is just a depiction of that epithelium here, where the high-grade serous ovarian cancer grows. I wanted to show this slide because it really brings light to all of the new approvals for ovarian cancer. It was very quiet for a very long time. In the 90s, we finally got carboplatin and paclitaxel, which really remain our backbone of upfront or initial chemotherapy for advanced ovarian cancer. But then finally, we get into the good stuff. We got bevacizumab in the 2014, and then the PARP inhibitors. And then more recently, we've had antibody drug conjugates like mirvetuximab approved. So a lot of work has been done the last 10 to 15 years that has really changed the landscape of advanced ovarian cancer. And we'll go through all of this. So this is a very busy slide. I recognize that. It's from Dr. Dave O'Malley at the Ohio State University. But I really like it because it shows you how we make our decisions, why we make our decisions at sort of each stage of the diagnosis. And so we'll kind of go through this line by line, and I do think it's really important to know that there are so many different decisions we need to make. The first decision is whether a patient will get upfront or initial surgery by a gynecologic oncologist to have the cancer removed, or if that surgeon feels like they cannot get all of the cancer at that time, do we do a little bit of chemotherapy first? So usually it looks like surgery, then we usually do 6 cycles of a chemotherapy, or we can do chemotherapy first, three or so cycles followed by surgery, and then 3 or so cycles at the end of that. So either way we can do. There have been a lot of trials on this, comparing the 2 different types of upfront treatment. And this is just one of them, the CHORUS trial. And it really shows that there's no difference in what we call overall survival between having neoadjuvant chemotherapy and then surgery, or surgery first followed by chemotherapy or adjuvant chemotherapy. During this time, we're also going to be doing biomarker testing. So biomarker or genetic testing, we 100% absolutely need the BRCA testing. This is a germline test, so something that has been passed down from generation to generation. And these are genes that produce proteins that can help repair damaged DNA. And you've heard about this. The BRCA is the breast cancer gene. So people have generally heard about this, but what they may not know is that about 40% of women who inherit the BRCA1 and less women with the BRCA2 variant will develop ovarian cancer by age 70 to 80. And then the incidence of BRCA mutations in the population, general population, 1 in 400, relatively rare. Ashkenazi Jewish population, 1 in 40 incidence. So a huge increase in incidence in this population. So if you or someone you know is of Ashkenazi Jewish descent, you should absolutely have testing for the BRCA genes. And then about 15 to 20% of all ovarian cancers will have this BRCA1 or 2 mutation. And then here at the bottom is just a depiction of a positive test. Next, we want to test the tumor itself. So we'll take a sample of the tumor and we'll send it off, and we want to test it for any genetic mutations within the tumor itself. It's also called somatic testing. So if you hear that, that's the same as tumor testing. What we really want to know initially is, does the tumor harbor a homologous recombination deficiency, which is a mouthful. We just call it HR or HRD for that deficiency. And this is a tumor characteristic that's really defined by the inability to accurately repair double-strand breaks in DNA. And different studies show different rates of this within the tumors, but probably about 20 to 25% of ovarian cancers do harbor this deficiency as well. And again, here's a depiction of a positive result. And we'll talk about why these are so meaningful and why we need them in future slides. Oh, I did want to just shed a quick light, give a shout out to our absolutely amazing Cancer Center genetics department. They do a fabulous job. But like, in Boston and all over the country and probably the world, genetic counselors are in high demand and there aren't a lot of them. So we are running into problems with patients not getting testing within quickly. So it was hard to get them in, and then the testing was delayed. We are missing people. So this trial that the genetics team is running has been working really well. They have 2 arms where patients are either randomized to get what they call an electronic decision aid. It's really kind of like an iPad that takes you through different options of genetic testing. And at the end, you pick the one that suits you best, or they're randomized to go see a genetic counselor up front, make the same decisions, and then get the test. Either way, you're getting a genetic test, but we're hoping that this has really good feasibility and it can be expanded to other centers, and that it helps people get genetic testing quickly. All right, the second decision point is, do we add something called bevacizumab to our upfront treatment or chemotherapy regimen? So like I had mentioned a few slides ago, the backbone of our ovarian cancer treatment, surgery, and then a platinum-based chemotherapy. Usually we use carboplatin and paclitaxel, which are both given through an IV every 3 weeks. Sometimes we'll want to add a monoclonal antibody, a drug called bevacizumab, and this is recommended for patients with maybe a poor prognosis, someone with stage 4 disease, maybe the surgeon went in, was not able to remove all the cancer. And then really in practice, it's often added when people have persistent pleural effusions, which is fluid in the lining of the lungs, or ascites, which is fluid in the abdominal lining. And it can really kind of help sop up that fluid and make people feel better. And then moving down to decision 3, this is where all that genetic testing comes into play. So people that are getting the bevacizumab with treatment, we look at whether or not they harbor a BRCA mutation and whether or not they are HRD positive or negative. So if they have a BRCA mutation, they hands down 100% should get a PARP inhibitor, and usually that one is olaparib. I'll show slides later detailing all of this. And then if the person does not have a BRCA mutation and their tumor is not positive for HRD, they could get a PARP inhibitor, but it's less effective, and a lot of people will choose not to do that. And then the other arm over here is people that did get bevacizumab during treatment. We look at the tumor, whether or not it's HRD positive or negative. If it's positive, they will benefit from adding a PARP inhibitor to the bevacizumab. And then the PARP and the bevacizumab in this setting after this initial treatment is we call it a maintenance treatment. So it helps to maintain that good response that we got to the chemotherapy. And usually we have people on these for about 2 or 3 years. Just gonna pause and take a quick sip of water. Okay. Another busy slide. Sorry, I do a lot of these talks for nurses, so I hope this isn't too much, but we'll go through it. So these are our first line maintenance studies. So remember, first line would be that first initial chemotherapy that people get, and then the maintenance is maintaining that response to the treatment with a PARP inhibitor or bevacizumab or the combination of the two. I did want to quickly go over phases and definitions of clinical trials because we're all from different backgrounds. Phase 1 focuses on safety and proper dose. It's usually a small number of participants. Phase 2 focuses more on effectiveness and side effects. And then phase 3 compares a new treatment to existing treatments. And these are big trials, hundreds of participants. The golden 3 that we look for are randomized, placebo-controlled, double-blind. So a randomized clinical trial compares the effects of different treatments by randomly assigning participants to groups. So the clinician is not assigning them, they're randomly assigned. Placebo-controlled compares the effects of a new treatment to a placebo or a fake treatment. And then double-blind, neither the clinician, researcher, nor the patient know who is receiving the treatment or the placebo. So the first step is the PRIMA trial. This study looked at newly diagnosed advanced ovarian cancer. All of the patients on this trial had HRD testing, so that tumor testing. And then they were randomized to get niraparib, which is an oral PARP inhibitor. All PARP inhibitors are oral, an oral drug taken for 3 years versus a placebo. So these are the results, and these charts, these curves are called Kaplan-Meier curves. And what we want to see, which is so beautifully depicted here, is this separation between the control and the placebo. So the niraparib and the placebo, look at this big gap there. That's what we want to see. So this really showed a benefit to maintenance niraparib. Bigger benefit in the HRD positive population versus the HRD negative population, but still a bit of benefit there as well. The SOLO-1 trial, this was looking at BRCA mutated newly diagnosed advanced ovarian cancer. So all of the patients had a BRCA mutation, and then they were randomized to olaparib for 2 years or a placebo for 2 years. And this trial completely changed the landscape of how BRCA mutated ovarian cancer is treated. Look at that beautiful separation of the curves and see how it extends beyond the treatment. So the treatment stopped at about 24 months and it extends beyond there. So the response is sustained, which is exactly what we want to see. And then lastly, the payola trial, this combined bevacizumab with a PARP inhibitor versus placebo and bevacizumab. And what we saw here again was that HRD positive group had a great response, 28 versus 16 months in the placebo arm. And this is how we got the olaparib plus bevacizumab maintenance approved in that HRD positive subtype. All right, that was a lot of information I just threw at you. So just to summarize, surgery plays a very important role in ovarian cancer treatment. It's really important to have your evaluation and surgery by a gynecologic oncologist at a high volume center. They can do a primary debulking, so surgery first, or we can do surgery after a couple cycles of chemotherapy. All patients diagnosed with an ovarian cancer should have germline genetic testing. And at the very least, we should be looking for BRCA mutations. This informs prognostics, future treatment plans, and it's important for family members as well. Upfront chemotherapy consists of platinum-based doublet, usually carboplatin plus paclitaxel, and this is given with or without bevacizumab. We usually use bevacizumab in patients with high-risk disease or with any pleural effusions or ascites. Based on germline and somatic or tumor genetic results, we can offer a maintenance therapy at the end of your upfront or initial treatment. And lastly, PARP inhibitors have drastically changed the landscape of BRCA mutated and HRD positive ovarian cancers. Okay, just gonna pause and take a sip of water. And then we're going to go into, so we've talked about the diagnosis, we've gone through initial treatment. So I want to talk a little bit about how these treatments work and some side effect managements. All right, so PARP inhibitors really work by blocking different pathways, DNA repair pathways that tumor cells may have. Once these pathways are blocked, reliance on error-prone pathways can lead to DNA damage accumulation and cell death in the cancer cell. Your own cells have different ways of repairing DNA damage. The three main side effects of PARP inhibitors are fatigue, anemia, and GI upset, and we'll go through all of them. The first thing we want to do is make sure the patient isn't anemic if they come in with fatigue. And remember, these patients are coming off chemotherapy, so they might have an anemia left over from their chemotherapy, but it will be important to check for nutritional deficiency as well, like iron, folate, B12, vitamin B12 deficiencies, and monitor as that goes on. Of course, you want to maintain a good nutrition status, stay well hydrated. Physical activity is very important, and it has been proven to help cancer-related fatigue. Even 10-20 minutes a day getting outside for a walk can have great implications on overall mental health and sleeping and all of that. Cognitive behavioral therapy, a lot of people are struggling with depression, anxiety. They're processing this diagnosis they've had. They haven't had time to process it fully because they've had surgery and chemo. And so once they get on maintenance treatment or come off treatment is when I see a lot of tears in the office. You know, they're really starting to grieve and process. Something like a psychiatrist, psychologist, a social worker can really help with this. Insomnia can play in fatigue. One of the PARP inhibitors, niraparib, can actually cause insomnia, so we like to give it in the morning. We can always hold the dose, which means we stop treatment for a little bit. We can always reduce the dose if things become unmanageable. And then lastly, I like to mention stimulants. We don't use a lot of them. Maybe we should be using more. I'm not sure. But when all else fails, I think is when we would introduce something like a Ritalin. Nausea, vomiting, I do like to tell people that usually I notice it most in the first 4 to 6 weeks with the PARP inhibitors, and patients can take a prophylactic anti-nausea medicine like ondansetron or olanzapine at night. But usually by about 4 to 6 weeks, people are kind of forgetting to do that, and then they notice they feel a little bit better. Of course, we can offer dose reductions or dose holds if this is very severe and they're losing weight. And lastly, anemia or other hematologic toxicities. Anemia is quite common, and we can do blood transfusions as needed and dose reduce and hold, just like fatigue and nausea. Thrombocytopenia or low platelets we see mostly in niraparib. So during the first 28 days, we're going to monitor with weekly labs. Neutropenia can happen, that's low white blood cells, but it's a little less common than the other two. All right, so that was the PARP inhibitors. I did talk about bevacizumab a lot, so I wanted to give a slide on that. The brand names are Avastin or Mvasi. It's also given through an IV, and it's every 21 days. The common side effects are headache and kind of like almost like an upper respiratory infection like syndrome, where people might get runny nose, some mild nose bleeding, voice changes, post-nasal drip, maybe a dry cough, headache. I see this all year, but especially heading into the drier, colder season. High blood pressure can happen in about 30% of patients, and usually we can manage this pretty well with an antihypertensive regimen. We'll be checking the urine for protein. Bevacizumab can cause the kidneys to leak protein. Dry skin, myalgias. I actually do see a lot of joint and muscle aches, especially like your neck and your knees. And then one very important thing is it can cause delayed wound healing. So inevitably someone will need like a tooth procedure, a dental procedure, an extraction, or maybe they're getting a port placed, something like that. And we will need 2 weeks around that procedure. So give the bevacizumab, have the procedure, and then 2 weeks later, we can restart it. Less common would be bleeding, thrombosis, and GI perforation. I wanted to dedicate a slide to carboplatin and paclitaxel because, like I said, they're a backbone of ovarian cancer treatment. I made the slide look really pretty and teal, but I guess these are sort of less exciting treatments at this point, but I did want to pay some respect to them, I guess. So this is more of a traditional chemotherapy. They work on damaging cell DNA and stopping cell division. Common side effects are things you would see sort of in the movies or that you hear about with chemotherapy, like fatigue, nausea, vomiting, low blood counts, and then the paclitaxel can cause body aches, neuropathy, and hair loss. Before people start chemotherapy, they're given a teaching session with one of our nurses or myself or our clinical pharmacist. And we have really good ways of mitigating nausea and vomiting. And so people generally do pretty well. All right, so we've gone through diagnosis and treatment. We've talked about how these drugs work and their side effects. Now you're done with treatment and you're now in something called surveillance. So what next? Well, the NCCN recommends, and we do follow this, that we see patients every 3 months for 2 years, then 6 months, and then annually. This visit will include a physical exam, including a pelvic exam, may or may not include a CA-125, which is a tumor marker that is elevated in some cases of ovarian cancer. And then usually we will get some radiographic imaging, such as a CAT scan, a CT scan. And then I do like to tell people that it can really take 3 to 6 months to start feeling like yourself again once chemotherapy is over. Give yourself some grace, get gently back into your routines, but you're not going to bounce back like that. People come in a month later for some post-treatment labs and they're like, I I thought I was going to be back to my normal self. It really does take some time. So give yourself some grace with that. And then neuropathy, if you did develop any during treatment, this can keep improving for about a year. So our hope is that it continues to improve. But after a year, you're probably left with what's there. And then this is a really good time to start focusing on mental health as well. It's important all the way through, but I found, and like I talked about earlier, people have this diagnosis and then they're all of a sudden they're having surgery and chemo and they have all these visits and they don't have time to process any of this. So again, I see a lot of tears in surveillance visits. The grief of losing, your sort of normal life before this, and then the fear of recurrence is a very real thing as well. So a good time to kind of get looped in with a mental health care provider, or just talk to us. We do have some great resources here. Lifestyle medicine is a great referral. They focus on lifestyle changes that can keep you healthy. They have support groups as well, which have been helpful for some of our patients. We have a great nutrition team. Cancer rehabilitation and physical therapy are referrals I put out often. A lot of people can become sort of deconditioned, or maybe they've had an altering surgery and they're just looking to get back to their normal sort of physical abilities. Sexual health, I always hope that people feel comfortable enough to talk to us about this. This is a big part of people's lives, and there can be a lot of changes during chemotherapy, or perhaps we put you into surgical menopause during that initial surgery for the ovarian cancer. So a lot of things have changed mentally, physically. We do have a sexual health team that we can refer out to, but we're always happy to talk about that as well. We have a psychiatric oncology program. So these are psychiatrists and psychologists that work mostly with cancer patients. And then our social work team is absolutely fabulous. I do a lot of referrals out to Livestrong, the YMCA program. People tend to like that. If you go to the National Ovarian Cancer Coalition website, they have all different sorts of resources. They have an annual walk here. So some really great resources there. And then Turning the Tide is an ovarian cancer retreat that I wanted to mention because we have had a lot of patients go to it. It's usually at like a really nice sort of cabin or hotel setting in New England, and people have really, really liked it. Okay, so future directions. Where are we headed next? So I wanted to talk a little bit about antibody drug conjugates, or ADCs. So the ADCs are comprised of three parts. The first being the antibody, sort of like the GPS tracking system that connects this drug with the tumor cell. And then there's a linker that actually links the ADC to the cancer cell. And then the cytotoxic agent, the chemotherapy, or what we call the payload, which is then injected into the cancer cell. Mirvetuximab was approved about 2 years ago, I want to say at this point. And this targets a folate receptor alpha, which is found on the surface of some ovarian cancer cells, and some of them it's overexpressed. There's a ton of them. So if we send your tumor off for testing and it's positive for folate receptor alpha, the patient is eligible for mirvetuximab, or ELA here. And this would be in recurrence. And then the trastuzumab deruxtecan, or Enhertu, works the same way, except for it's targeting HER2, which is the human epidermal growth factor receptor, and is responsible for cell growth and division. And just like the folate receptor alpha, it's found in excess on some cancer cells, and it's approved for HER2 solid tumors, including ovarian cancer. Again, this is all in recurrent setting. Clinical trials. When do we evaluate for clinical trial? The real answer is at every stage. So we've had in the past some clinical trials with upfront treatment. And then usually we do a thorough review at times of recurrence or any progression of disease. So God forbid, you or your loved one comes in and you have a progression of your cancer or a recurrence of your cancer, you would be evaluated for clinical trials at MGH. So we have a bunch of clinical trials right now. Two excited ones that I wanted to highlight are the Regeneron clinical trial, which combines a bispecific antibody. So this is binds a tumor cell to a T cell, which is an immune system cell. And then it's combined with various things, another bispecific antibody, and there's an arm with immunotherapy. And we've seen some great responses on this. And then we do have a phase 1 team as well. And we're working on some newer antibody drug conjugates with maybe the same receptor targets, but potentially less toxicity. So that's an exciting one as well. And that's it. Thank you so much. I'm happy to answer any questions. I'll go ahead and stop sharing now.
Thank you so much, Jenny. We are now at the end of the session. If you have any questions, feel free to enter them in the chat. We have a question regarding the clinical trials you had mentioned. Where can one go to learn more about it and whether they're eligible?
Yeah, so I'm sorry, I'm just taking some water. If you're a patient here, you just talk to your oncologist and they can give you our clinical trial profile and go over what you may or may not be eligible for. And if you're not eligible for something here, they could connect you with another center. And if you're not a patient here, the oncologists are always happy to do second opinions.
Thank you. We have a couple of general questions about ovarian cancer. Who
Okay.
is at higher risk of ovarian cancer?
That is a really good question. So risk factors would be older age. Like I said, that median diagnosis is 63. Having a BRCA mutation puts you at risk. Some protective things are women that have had a baby or more. People that are on birth control actually have a potentially lower risk.
Does that mean, can it affect younger women?
Women that are younger can absolutely get ovarian cancer. I've seen everything from maybe age 18 or 19 on to 99. So anyone can get ovarian cancer. And sometimes, usually what we see is the younger patients may have some sort of germline or BRCA mutation, but that's not necessarily true in all circumstances, certainly. Usually it is a random occurrence. Remember, only about 20 to 25% of ovarian cancers are related to a BRCA mutation.
Thank you. We have a general question about whether fibroids or ovarian cysts are related to ovarian cancer.
That's a really good question. I do not think so, to my knowledge.
We have a question regarding genetic testing. Is
Okay.
additional genetic testing recommended if it was done 14 years ago when they were first diagnosed with endometrial and stage 1 ovarian cancer?
Oh, that's also a really good question. So I think it depends. So a lot of the genetic companies, I'm not sure which one that you used, but a lot of them will offer sort of like new testing as they go along, or if anything has changed, they should be reaching out. But if it's been that long, you could try. You could see if your insurance covers it. I don't think it's necessarily needed, but certainly if there was a recurrence, we would want more testing, I think.
Thank you. And towards the end of the presentation, you had provided some great online resources. Do you mind summarizing those online resources again for those who are interested in learning more about ovarian cancer, treatment options?
Yeah, so I highlighted the National Ovarian Coalition, NOCC. They have a great website, lots of resources on there. And then the other one I mentioned was Turning the Tide. I think you can just type that in your web searcher, and that will pull up their website as well. And then I did mention a bunch of stuff that MGH in particular offers. The Cancer Center website will mention a lot of these things, but you can also talk to your provider. We should be able to give you a good comprehensive list.
You did mention lifestyle medicine. I did want to put a plug in. We are actually hosting a program on Friday, November 1st through Zoom, and it's going to be exactly on that topic with the lifestyle medicine team. So if anyone's interested in getting more details about this upcoming webinar, feel free to email the Blum Center at pflc@partners.org, and I'd be happy to share that flyer with you as well as the Zoom link to attend.
It's perfect.
So while we see if there are any additional questions in the chat, do you have any final thoughts you'd like to share with the audience?
I don't think so. I just hope that, you've learned something today and that this kind of helps to spread awareness. Um, and yeah, I usually present to nurses, so I hope it wasn't like too much, too many numbers and all that. So thank you for having me.
Thank you for joining us. I had just put in the Blum Center website in the chat, so if anyone's interested, feel free to email us. And I did mention that today's session is being recorded. If you're interested in viewing the recording, it'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Right, so I don't see any additional questions in the chat, so I think it'd be okay to end a few minutes early. Jenny, thank you so much for spending the hour with us. This was extremely helpful.
Absolutely, my pleasure. Thanks again.
Thank you everyone for joining today. Take care.